My name is Andreas Engert. I'm chairman of the German Hodgkin Study Group and I work at the University Hospital in Cologne, Germany. Today I want to discuss a case with you of advanced stage Hodgkin lymphoma. So this is a typical case. He's 32 years old. He experienced or noticed some lymph node swelling in his cervical regions and also in his axillae, and he also developed B symptoms such as fever and heavy night sweats. It took a while before him deciding to go to a doctor, see a doctor. The doctor took out one of his cervical lymph nodes and the diagnosis of classical Hodgkin lymphoma was made. He then underwent scanning, CT scanning, and this showed that multiple lymph nodes were involved, also in the mediastinum or in the abdomen. He also had bone marrow involvement, so he was a stage 4 Hodgkin patient. And you know, for these patients there are risk factors in the IPS, International Prognostic Score, including stage 4, male disease, leukopenia, lymphocytosis, anemia, and so forth. So he had 7 of these risk factors, and this really means that his prognosis was pretty poor, particularly when treated with ABVD. You know that the index was built on patients treated with ABVD. So with 6 of 7 risk factor in this patient, he would have a prognosis of around 50% long term. The question then to you is, what would you do with such a patient? There are a couple of options certainly for treating this patient, including 8 cycles of BCOP escalated, followed by radiotherapy, 6 cycles of BCOP escalated, 6 to 8 cycles of ABVD, Stanford 5. So this would be the major options. You can choose what you would do. Well, we treated this patient with 6 cycles of BCOP escalated. That would be our recommendation, and that would be on the basis of our HD15 trial. You know that the prior trial or an earlier trial, HD9, established BCOP escalated and showed that this was more effective than COP ABVD. However, it was also more toxic, so we decided to try to reduce toxicity in the follow-up studies. This didn't work for HD12, but it worked for HD15, where we compared 8 cycles of BCOP escalated, followed by radiation with just 6 cycles of BCOP escalated and 8 cycles of BCOP 14. And surprisingly, we were able to show that 6 cycles were superior, both in terms of PFS, that's tumor control, and overall survival. So that clearly changed our standard now to 6 cycles of BCOP escalated. And as far as radiation of residual disease is concerned, we did a PET in those patients who had 2.5 centimeters residual disease after chemotherapy, and only those PET positive patients were radiated. So that were a total of 11% of the patients in this trial in HD15. And if you look at the curves, if you compare those patients who did not have radiotherapy and those with residual disease having radiotherapy, you see that the curves are different, 10% or so. But on the other hand, the curve that received, or the patients that received radiotherapy, did not do very bad. It is a little bit worse, but it's rather a good tumor control, we think. So this has been picked up by many other groups, in that patients who have residual disease in advanced stage patients stages receive additional radiotherapy. And overall, the prognosis with 6 cycles of BCOP escalated plus this targeted radiation is close to 90% at 5 years tumor control and 95% overall survival, and that was achieved in a large international study with 5 countries contributing, 400 centers. So we think that this is a good treatment. Certainly we want to detoxify this even further with the advent of new drugs such as brentuximab vedotin. There are trials ongoing now combining chemotherapy in first line with this drug, and we use this drug to detoxify BCOP. We showed this in a phase 2 study, and we will now compare this in a large randomized phase 3 before we have the results of this trial, and this will take another few years, certainly 6 cycles of BCOP escalated, followed by targeted radiation would be our standard of care. Thank you very much.